Question 8, which of the following is the most likely underlying cause of this patient's condition? Again, unhelpful. Quickly scanning the answer choices, we have parathyroid, B-cell, autoimmune, metastatic, monoclonal. Okay, this is all over the place. I really, even with my tried and true patent pending premedicated test taking skills, I have no idea what's going on here. And that's okay. That happens sometimes. Now we just go through and read this question like normal. So we've got a 69-year-old man presenting with 3 months of worsening fatigue and intermittent back pain. He denies trauma, but says the pain is worse at night and when standing. He also reports increased thirst and constipation. Past medical history includes hypertension and GERD. Physical exam shows no focal tenderness, lymphadenopathy, or organomegaly. Neurologic exam is normal. And then we've got a laundry list of lab work here. Notable ones would be the anemia. There's always anemia. There's calcium, hypercalcemia. Creatinine is high. Total protein is high. That's a strange one. You don't see that one very frequently. And then albumin is low. Another one you don't really see too much of. UA has +1 protein. No red blood cells or casts. So a lot of positive lab findings. I'm hoping this is kind of ringing the multi-system alert bell in your brain right now when we've got anemia, hypercalcemia, and then creatinine. High creatinine, what's high creatinine mean? Please, Dora the Explorer. Kidney damage. Perfect. All right. Acute kidney injury, maybe chronic kidney injury, some kind of kidney injury that is causing us to not be secreting as much creatinine as we're supposed to. Same thing with BUN. If you have high BUN, it's another sign. Creatinine, I believe, is just more specific because you don't reabsorb any creatinine, unlike BUN, where you do reabsorb BUN. So we're just going to go ahead and kind of spell things out here. All right. We've got low hemoglobin, so we have anemia. We've got our anemia. We have hypercalcemia. Okay, so we've got, I'm just going to write out the letters here. C for calcium. We have high creatinine, so we probably have some renal involvement. Great. And then proteins. Yeah, I don't know what protein means. It doesn't come up in questions very frequently, so I don't really know what that means. I don't know how to interpret that. Let's say we're going on here. We've got, going back to the stem, 3 months of worsening fatigue and intermittent back pain. Okay, so we've got some back pain. Oh, look, a crab. I don't know if you've ever heard of crab mnemonic, but it is quite literally pathognomonic for multiple myeloma. Boom, we solved it. Easy. This one, there's a ton of stuff that we can learn from in this, though. Let's just keep going. Denies trauma, pain's worse at night, and when standing. Pain worse at night is often indicative of tumors. Tumors are infection usually, but classically tumors. So pain worse at night, especially when you're lying down, it doesn't make sense to be mechanical pain if you're not really moving. He has increased thirst and constipation, hypertension, GERD. Okay, and that's pretty much it. There's another mnemonic though to help you out with hypercalcemia. You've probably heard this one before. Stones, bones, groans, psych, over / undertones, whatever your cup of tea is. So just keep an eye out for these two mnemonics. They're very useful. Stones, bones, groans, psycho, overtones. Let's see if we have that here. I mean, we know we have hypercalcemia from the labs, but do we have kidney stones? Maybe not, but we do have elevated creatinine. We don't have mention of kidney stones specifically, but when you do see elevated creatinine, it shouldn't be off your differential list entirely. Bones just means bone pain. Bones could be just bone pain from calcium reabsorption. And we definitely have back pain, right? So that could be the bones. Groans is a funny one. Groans refers to constipation. Hypercalcemia actually slows down peristalsis. So groans, we've got that, our constipation. And then psych, over, undertones, that could be anything. Confusion, anxiety, depression, literally anything. I don't think we have that one, but we do have 2 of the other hypercalcemia symptoms. All right, now, can we make sense of multiple myeloma with the rest of the labs? Well, ask yourself, what is multiple myeloma? Multiple myeloma is a tumor that secretes antibodies. It's a plasma cell tumor that tends to make itself homey in your bones, right? Hence the bone pain. And it tends to upregulate osteoclast activity, causing more bone pain. Multiple myeloma is a plasma cell tumor. Plasma cells, what do those do? They make antibodies. Antibodies float around your blood and tend to deposit wherever they please. So that's why multiple myeloma is a multi-system disorder. Just like the honey badger, multiple myeloma don't care. So which of the following is most likely underlying cause of this patient's condition? Excess parathyroid hormone. So we already know the answer, but let's say we didn't. How can we eliminate as much as possible here? So excess PTH. What does PTH do? It increases calcium, decreases phosphorus. We have increased calcium, no mention of phosphorus. So that one, honestly, I'm not going to eliminate that one just yet. There's no Proof. B-cell lymphoproliferative disorder. So like a B-cell tumor. Maybe, but probably not when the white cell count is normal, but maybe. I mean, it's totally possible. So I'm gonna go with probably not, but maybe. Autoimmune glomerulonephritis. So glomerulonephritis would probably increase our creatinine, but the itis part in nephritis means inflammation. Inflammation means hematuria. UA shows no red blood cells or casts. So it's probably not a glomerulonephritis. We do have protein, but this is not enough protein to be a nephropathy either. Classically, to diagnose nephropathies, you need 3.5 grams of protein in a 24-hour UA, or I believe at least 2+, maybe even 3+ protein. So this one also a no for me. Metastatic prostate cancer. This one we hear all the time with back pain and in older men. So this is a good setup here. Metastatic prostate cancer. It's definitely possible because you don't always see the obstructing system. The obstructing symptoms, like the urinary obstructing symptoms with prostate cancer, as you would with a benign prostatic hyperplasia. So that one's possible, but how does it explain the hemoglobin or the creatinine if it's not obstructing, or the total protein or the albumin, right? So like it doesn't make as much sense. And we can even apply that logic. I don't know. I didn't think of this earlier. We can apply that to the parathyroid hormone either. Like how is anything explained by all of these except monoclonal light chain deposition? Monoclonal light chain just means lots of the same antibody. Guess what plasma cells make? Tumor plasma cells make the same antibody. Hence, monoclonal light chain is just part of the antibody. So the answer is E. This is your classic multiple myeloma question. I strongly encourage you to add the crab mnemonic and the stones, bones, groans, and psych over and undertones to your Anki deck if you don't already have it in there.